Some of the main advantages of following MTM are individualization of the patient therapy, cost-effective treatment, and also improved patient satisfaction. Our pharmacy student, as an expert in clinical pharmacy, performs the daily clinical rounds along with the consultants and do the prescriptions and therapeutic audit for both inpatients and outpatients, and also troubleshoot any identified drug-related issues by suggesting the interventions. This also compassionate the patient counseling, which is a vital information communications with the patients. The ultimate goal of our department is to continue streamlining this process of serving the patient better to enhance the care and safety of the patient.
Here are some therapeutic interventions. In this case, domperidone and fluconazole was co-administered. We approached the consultant physician regarding this interaction. The suggestion to change domperidone to metoclopramide was welcomed and changed. We all know that levothyroxine requires an acidic environment for an optimal bioavailability. When it's administered with pantoprazole, its absorption can be affected, resulting in TFT derangement. The suggestion was to administer pantoprazole at least 2 to 3 hours after levothyroxine. Anemia can be a major complication if untreated. In this case, patient had normocytic normochromic anemia and wasn't treated. Suggestion was to add ferrous fumarate and folic acid supplement. In this case, diltiazem 30 mg twice daily was changed to thrice daily by the physician, but the prior one wasn't discontinued. This was recognized and suggested to discontinue the BD dose. Patient was prescribed fenofibrate. When the patient's previous history was thoroughly checked by the intern, it showed that patient had a history of adverse drug reaction to fenofibrate. This was brought to the notice of the doctor and was discontinued. Administration errors. Incorrect calculations can result in patient receiving a higher dose than necessary. Doctor ordered to start infusion noradrenaline of 0.2 mg, which should be administered as 2.5 ml per hour infusion. The formulation available is 4 mg, 2 ml, which had to be diluted in NS to make 50 ml. But due to wrong calculation, nurse started with 10 ml per hour. On advice, changed the rate of infusion to 2.5 ml per hour. In this case, the nurse was confused as pyrazinamide was prescribed twice, one as 500 mg and another as 750 mg. Pyrazinamide, which was scheduled at 9 p.m., wasn't administered. The nurse was suggested to give both the drugs at the respective time because the dose of pyrazinamide according to body weight of the patient was 1,225 mg. As a single formulation of 1,225 mg was not available, divided doses were written. Storage errors. Keeping unused drugs in the bedside is unsafe. We follow a system where all unused drugs are kept in the red pouch, which can reduce confusion in administering the medications. Here is one case where the nurse was suggested to keep all the unused drugs in the red pouch. Here is another situation where magnesium sulfate injection, which was not prescribed to the patient currently, but was found at the bedside. The patient was receiving it before, but was discontinued few days back. The nurse was suggested to put that in the red pouch. Degraded H-mixtard, clumps with precipitation, was present in the bedside cupboard. Suggested to discard and replace it. Here are some adverse drug reactions. Clobazam-induced drowsiness. Telmisartan-induced hyponatremia. Azithromycin-induced transaminitis. Cefoperazone sulbactam-induced rashes. Paracetamol-induced drug eruptions bullous. Please subscribe to this channel for more videos. Thank you.